Hello everyone and welcome back to another episode of the IDRiM podcast. Today's episode is a continuation with Kadia, and in this week's episode what we're going to do is look more at data, and in particular data in healthcare systems and in data in healthcare system emergencies. This is obviously a very topical topic right now, given the situation going on in the Dominican Republic of the Congo, in particular with the Ebola outbreak, and it was a big topic during the COVID-19 crisis. We'd also like to apologise for the delay in uploading this week's episode. Sadly, I've recently suffered a bereavement, and that has meant that my ability to edit and these episodes and upload them has been hampered. And lastly, we would also like to apologise about the audio in this episode. The way that the audio has come through is that Kadia, when she first speaks, is very quiet and then it gradually will build back up. We've tried to edit this out as much as we can, but this is the best we are able to do. But we hope you enjoy today's episode.
Now, you described in your paper about, and you've already mentioned it a bit earlier on, that there are parallel reporting systems, and in your paper you say that it's paper forms, it's Excel spreadsheets, it's DHIS2, and they're all operating simultaneously. My question is, and it's a 2-point question: why is there 3 systems, and why has the system become so fragmented?
Yeah, at the time, I think that at the time that I wrote this study, one thing was true: the health system, data generating aspect of the health system was not as sophisticated as it is now, and there is a high dependency on paper mode of reporting. And so there was, during that time, the health system was trying to transition into an electronic mode of reporting. But in Cameroon, we face internet issues, staff issues, and so there is this need for a backup. Now, even though there is this need for a backup, the requirements for reporting public health emergencies hasn't changed. For instance, you need to report diseases under epidemic diseases of epidemic potential within 48 hours. The report needs to move from the community to the central level. However, within these 48 hours, they have to enter the data, so line list the data from the registers, enter it into the paper reports, transfer it into the Excel sheet, and at the district level, where the district level only has the district level, in addition to the paperwork that they receive, they have to enter this data into an Excel sheet, then transfer from an Excel sheet into the district health information system. Within that time, you need to, if it's a case of cholera, you need to report that case of cholera within 24 hours. You need to report that case of cholera. The case needs to have been validated and the sample should have been collected. So you see that the energy and the resource put in place to ensure reporting penalizes the effectiveness of the surveillance system, because it will be so difficult for a cholera case to be reported within 24 hours if all those parallel data entry points have to be made. But yet, there need to be traceability. If you are reporting a case of cholera, they need to validate it, they need to see it in the register, then see it in the weekly reporting form, then see it in the monthly reporting form, then see it in the sample collection. So there are so many paperwork, some are redundant, and you know that's how the system looks like at that time. That's how the system looks like at that time. So really, it was seen as a necessity for them to be able to trace and account for resources that are used during the outbreak.
So my question has become, you know, I get the need for a paper and a digital system, and I think, again, if you come back to UK, in the UK, I think we've kind of shown that need because we went all one way, which was all digital, but then we had a problem of cyber attacks, and the risk the cyber attacks poses to our healthcare systems. So actually having a paper version is always useful in the event that, these, unfortunate incidences happen. But my question is, why two sets of, digital forms, the Excel spreadsheet and then this, reporting system as well for infectious diseases? Surely they both can be merged together to be just one system of reporting rather than having, replicating the same process, the same data into two digital systems, which, okay, may have different purposes, but surely that's quite energy intensive, labor intensive, and actually resource, intensive later on.
Yeah, you see, each entry level is sort of serving as a backup for the newly introduced electronic version. The paperwork serve as a backup for the Excel sheet, and the Excel sheet serve as a backup for the DHIS tool. The DHIS tool uses the internet, so you can at times there's a breakdown of the system. So when you're trying to transmit the data from the regional level to maybe the central level, the district level to the regional level, there may be so much delay. So in order to have a backup, they will have the Excel sheet that they can send through email, and they attend to the situation while waiting for the DHIS tool to come back to function, to get back to be effective. So that's a bit how it was thought out. Yeah, to answer your question.
My next question is more of a personal one on it. Do you think it's a good system then? Because I I mean I understand the backup and I understand the connectivity issue, but it just for me, from outside, it feels it's one. I know in healthcare there should be a lot of backups, but I just feel that personally it's one backup too many. That the paper version or the Excel should be the main one. Because if the Excel spreadsheet is able to go to a more central control to be input in any case, well, then it raises a bigger question: why is this person at this local level doing the paper version, the Excel spreadsheet, and then the government system, when the Excel spreadsheet could be sent to the government system automatically via email?
Yeah, personally, I think that it's a more recent thing in Cameroon that uh, the importance of data has increasingly been highlighted in various areas of the health pyramid. And the data generating and transmission system was a bit rudimentary. It was a bit rudimentary, and data specialists were very limited, at the time. So I believe that this is some sort of, a way to get things done, a way to get things done and to respond to the challenges that they had been facing. However, I think this wasn't the most effective way to get things done. It wasn't effective because it was time consuming, resource consuming, and at the same time it didn't give the result that was expected, and it took quite a long while for the system to identify that this way of operating actually didn't yield the result. So for me, the question I'll ask is, why wouldn't they have a system that flags such such major gaps, such major discrepancies? The system is unable to flag all of that. You cannot have the system reporting Ebola when there's absolutely one Ebola death, but you don't see any case of an Ebola case reported. That's very dangerous. And that was data that I collected retrospectively, meaning I collected that data in 2020 when it was reported in 2020 in 2018. So 2 years after, nobody noticed that that data was showing that kind of figure, and it affects so many other areas of the Cameroon system. As I told you last time, especially the tourism system. If you look at the DHIS2 and you see Ebola, you don't. It's not everybody that wants to verify that. Okay, but this is a mistake because I'm not seeing a case, but I'm seeing a death reported. How couldn't they have identified a case but have identified a death? So you can understand that it's a mistake. But once somebody just sees Ebola, not everybody will go through the pain of fact checking or anything. So it's a very our health systems data generating process still has a long way to go, I must say.
Yeah, and it's not a criticism, of the system in terms of, it's pretty it's pretty early days, in its lifespan. I mean, when did you start using like this, digital system, centralized digital system?
Sorry?
When did you start to use a more centralized digital system in Canada?
Decentralized system?
So like a centralized system. So DHIS2. When did you start using that type of system?
2018. In
Right. So
2018.
yeah. So the reason I asked that question is that in the UK, we started using similar style of systems, in the early 2000s, and we had a lot of teething troubles, and I know we had a lot of teething troubles, and there was a lot of, and we kept paper backups even then as well, because we were worried, basically the same issues you do, in Cameroon, I've had the same worries because it's a learning experience when you move from a paper-based system to a digital-based system, and every healthcare system is going to have, that does do that transition, will face these types of issues. It's not it's not a surprise we hear, these, issues are being reported because every country, that's had to do this transition. I've had the same problems, and so actually, this is me leaping to the defense of the Cameroon healthcare system. Is that this is not a unique problem to Cameroon. It's a problem that every country, even developed economies have had to face in recent years.
Yeah, you're right. You're right. I mean, we're work in progress in that domain, and we are doing quite well between 2018 to 2026 that we're speaking. A lot of work has been done. DHIS2 has been vulgarized so much. You know, they have online training courses, free training courses, and when you put that in your CV, when applying for a job, especially one that will require you to work with data within the government space, you are very sought out for. So they've really done a lot of work.
Yeah, and I mean, getting the sense just talking from yourself, I can tell a lot of work has been done, to digitize the healthcare system. Now, some people argue that healthcare systems, shouldn't be fully digitized because there are risks attached to it, but you become over reliant on modern technology, than traditional nursing and traditional healthcare. I mean, in the UK, a good question would be how many nurses and doctors can go back to more traditional ways of you know ventilation, traditional ways of doing blood pressure checks, without a machine. And basically, it's one of them things where my personal opinion is actually, using it's great having a digital system, but always have the backup system like, Cameroon still has, the
Yes,
paper.
definitely.
It is extremely useful and valuable still to have it. It's just something that came to me about DHIS 2. In this digitized system, um, is the data, historical data, being digitized as well, or is it just all data from 2018 onwards being digitized?
I believe 2018 upwards.
Okay.
2018. Yes.
Yes, because the reason I ask is that in the UK, we embarked on a project a few years ago to digitize all healthcare data. Um, that includes every patient record going back to 1948 to be digitized.
Wow.
Which so I mean I can see I've seen my my grandparents health records. You can see it goes right back to the 50s, and what procedures they've had done. But also that raises other questions: is that is can the data be mistakenly put in, because there's that much data that needs to be inputted in a short period of time, there are then risks. So sometimes digitizing data does make mistakes, and you've got to be careful on what what how you input the data, because
Yeah.
sometimes I think that we prioritize speed over accuracy with data input. I don't know if you feel that that is a issue as well.
Yes, that's the issue. I termed it pressure at work. Uh, you know, we should have as leaders in the health sector recognize that there are certain methods that are not that don't generate the same results in the health sector as they would generate maybe in the mining sector and so on, because we are talking about people's lives here. So you cannot exert a certain amount of pressure on an individual to deliver when they are managing very delicate and sensitive information. But as I mentioned during the outbreak, that was what was happening. You have to report cases from the community right up to the district level to the central level within 48 hours, with all the challenges including the road network, the poor internet connection, unavailable staff. You have to deliver. And in that case, I remember when I used to work in a certain remote area, they used to say, if you want data, we will give you data. And what that implied was, okay, you want figures, we'll give you figures. Those figures, they are not the reality on the field, but because you keep pressuring them, you need information. They give you the information so that you stop pressuring them. So we need to start exploring alternative ways of, getting health staff to deliver on, especially data related issues while keeping the integrity of the data. I think that's a very big challenge in the health sector at the moment.
And just to come back, to the UK, and you know, if you look at my medical records, because I have access to mine, I noticed that in my medical records, a lot of data is still missing. That I know is missing. So, in particular, vaccination records, in mine are incomplete. So, I know I've had a polio vaccination, back
Yeah.
in 2006. It doesn't show up on any of my medical records that I've been vaccinated against polio. And it's like, well, I know I've been vaccinated, or tuberculosis. I have, in 2007, I was vaccinated against tuberculosis, and you can't exactly miss it because it's left a scar on me. And yet, my medical records don't show it was done, and that was because it was done by paper. And that paper record, wherever it's disappeared, has gone missing, and it never went into the system properly. So and even today, um, my influenza vaccinations don't get inputted into a system that I've been vaccinated. It's injected, written on a piece of paper, and that paper's never transferred to my doctors to say that he's had this vaccination. Now, if I have a reaction to that vaccination, a really bad one, and I need to go to the hospital, it's not in my records that I've been vaccinated, so they won't know how to treat me because they don't know they won't know what's happened to me. So I think that this is a highlight that even in 2026 in the UK, our records, digitized paper, are still fragmented ourselves, and we still haven't got it, correct. And we've been on this process for about 20 years, and we're still not there yet. And that just kind of goes to show that no, and we're in the UK, not to say boost us up, but we're supposed to have one of the more advanced healthcare systems, and yet we can't even get it right still. So it feels like that we are, that no country's got it right, and actually any critiques of countries that are getting it wrong, who are new to the game on this, it's actually quite appalling because it's not, it's because no one's got it right,
Yeah.
and it just feels that any critique is, it makes me angry with any critique, but countries are trying their best, but being unfairly critical is not going to help them.
Yeah. The UK is quite ambitious to go back to 19 to the 19 to get the data and update is very ambitious because you see there will always be this left out data, missing data, and all of that. You need to really have put in place a system to track and to be able to cover those gaps. It's very problematic, and it can have a lead to very poor prognosis for people if you are relying on such data, for instance, and you go to the hospital and they don't know how to treat you because your antecedent doesn't reflect your reality. Yeah.
Yeah, and in the UK as well. So I know for a fact that, so 2 years ago I was vaccinated against yellow fever, and I got told, they gave me like a piece of paper and they told me you need to go to your doctor's surgery to input this data. There's no system between vaccination centres and pharmacies
Wow.
and the healthcare system. It's still that fragmented. I mean, so, and it's actually, if you look on my vaccination records, I'm just looking at it now. There's still it's actually in there. It's been inputted,
Mm-hmm.
but it's not being inputted in the correct way. Still, it. So if you look at vaccination records, there's nothing there about yellow fever. But if you put in my document records, it is there. Just like, hang on, why isn't that being inputted into vaccinations when it's a clear vaccination? When it's not a document, it's an actual vaccination with the code and everything. But really, anyone's medical record should actually have. Yeah, so that's just a little insight, and on the screen I'll show what it looks a little bit like using my own data. So we've been talking a lot about data now, and your paper, and I know in the previous episode of the podcast we've talked a lot about the conflict in Southwest Cameroon in particular. What does actionable data look like in a conflict zone?
First of all, actionable data, the way it's presented, the way it's documented, the way you need a level of groundwork to be done before that data is collected, to understand why are we collecting the data, and how should we collect the data, and how do we you know do we ascertain that this data is valid. Now, one of the major challenges that we've been experiencing in terms of data collection during emergencies is getting disaggregated data, data that can inform specifically who needs what. A lot of times we collect aggregated data, and they give us a sneak peek of what is happening, but we don't know where to act. One way to address this would be to ensure that our data is disaggregated into the various genders, disaggregated into the various ages, into the region and the locality, and more. I'm pushing to, one of my plight is to really see that data can be disaggregated into your displacement status, to understand if you are displaced, if you are based in that particular locality, because that also helps us to understand the dynamics of the disease, to understand how the disease is moving, and we need that data to be disaggregated, and for us to understand all the various relevant aspects that data needs to be disaggregated into. We need this collaboration. We need interdepartmental collaboration, a sit down, so that we can, the Ebola is a zoonotic disease. That is a disease that is caused, that is contracted through animals. You see, so it's a zoonotic disease. So this brings an interplay between the health sector and the veterinary sector, or the agricultural sector, if I can put it like that. And so we need to recognize that in the midst of an emergency, we need everybody to think towards the same goal, towards the same vision. We should not uh, you know, divert the resources and then act blindly. No. So during emergency, actionable data is data that is wholesome, it's comprehensive. Actionable data is data that when you look at it, you see that even a lay person can interpret what is happening, where it is happening, who is being affected, and uh, communicating. It helps to tailor risk information communication. For instance, when I was doing my studies, the Bakassi health district was the district where the outbreak started. But when you look at the communication that was sent out, the same communication that was sent out through the local channels, the media, is the same communication that was targeting Bakassi, but that's not what's supposed to be. Bakassi is supposed to receive another communication. Is supposed to receive communication that is specific to their context, is situated in, around water bodies, so they need to get, sensitizations that are specific to that area. We cannot do that because the data does not allow us to do that. The data does not allow us in practice to do it. The data points that we collect are routine data points that in emergency settings don't are inadequate. That's why you see systems like the WHO early warning and alert and response system come to support the surveillance system during such emergencies.
So your paper argues that the system was, highly sensitized. So how did this slow down outbreak response, in this region? Because I know that we've talked before about, the outbreak. It was too late sometimes, to respond to the cholera outbreak. So how did this centralized system slow down that response?
Oh, that's a very good question. The centralized system has not really played in the favor of emergency response because it, it, it the first component is the financial component. Is the financial component because uh, the decision making at the time was done at the central level, and the peripheral level needs the okay from the central level in order to disburse funds to respond to an emergency. So obviously emergencies cannot be responded to within a specified period of time. It specified the bureaucracy was just too much to get data through the three channels that we spoke about, to move from the district, the regional to the central level, and then get a retro feedback before acting on a case of cholera that you identified 3-4 days ago. Obviously, it must have spread to a good number of people. Now we had other supporting partners that came in with the performance-based financing, as I earlier mentioned. And what they did was, uh, uh, empower health facilities to be autonomous, to be able to generate funds through good performances, to be able to generate funds. And through these funds, they were able to have some sort of emergency fund, and this emergency fund, during such a public health emergency, you could clearly see that districts such as the Kumba Health District that did very well under the performance-based financing scheme had a very high data completeness and data timeliness during our study. And that wasn't primarily because of their proximity to the area of reporting, but that was because they had funds to be able to address emergency issues as they came without necessarily depending on the central level to vet their their report before disbursing funds. Yeah.
So one of the things to say is better financing is actually a good way to get a better turnover in response in these outbreak areas.
Yeah, the better financing and also, you know, health facilities should be autonomous. They should be autonomous and they should be able to respond to emergencies, and then they can produce a report based on, the resources that were spent and all of that. But a restriction to saving life should not be to await a response that you really don't can't tell when that response is going to arrive. So they have to be autonomous. They have to have a system, an emergency package that they can utilize when such circumstances occur.
Yeah, and that taps into a debate that some people have, which state that actually decentralization of healthcare systems creates too much management and not enough focus on patients, which then means that you are sapping resources, financial resources, away from the front line. I mean, do you agree with that analogy, or do you think that that's a bit too generalistic on what happens in the front line?
Yeah, I think that's that's a bit generalized, and you know the need for finances can be can be minimized depending on what we are talking about. If we're talking about an emergency that is claiming the lives of so many people, we cannot take the risk of, you know, start saying, oh, it allows people to be more of, authority, and not, not focusing on the front, on the disease and the patient. Rather, they are focusing on managing the money. Yes, it can we can think about it. We can think about it that way when we're talking about other diseases, but not in cases of public health emergencies. Public health emergencies, like Ebola and all the like, you can always ask for accountability after a certain period of time. But while on the spot, the priority is saving lives. The priority is saving life. And if it takes, a couple of francs or to be missing, I think it's a risk that can be taken at that point, because when you weigh it, you see that it's better to save a life than to save money. And at the end of the day, you can always do the accounts, and then those who, if there was any mismanagement, then there will be accountability. But at that point, we cannot be talking about that when, it's an emergency.
Yeah, and I mean, your paper actually highlights this, point even more, you know, well, is that it mentioned the districts often lack the authority or resources to act without approval from the center. So how dangerous is that? During a fast and moving outbreak that cholera can be, to try and contain it before it spreads even further.
Yeah, yeah, it's a very dire situation. It's a very dire situation to sit there and a whole team is helpless. You're ready, you have the manpower ready, but you don't have the resources to go down to the field. At that time, during emergency, you need to, you just don't need to send staff on the field to go and respond to a disease, because you might be putting more lives at risk rather than saving them. So they need equipment, the transport sample system has to be, ready to, you have to identify laboratories that can examine that particular kind of sample. So all of that takes into consideration resources. And if you have to wait to get that information from the regional level, it's just very, it will impact very negatively on the overall containment of the disease.
Hmm. And imagine, I mean, the minute the biggest threat that highlights this, in the world right now, and I keep mentioning throughout these previous episodes and this one as well, is Ebola. And it's critical to respond straight away, but respond in a way that is well responded, because you can't just send your healthcare worker straight into without the proper equipment, the authority. But you also need to react very quickly, because Ebola spreads extremely quickly, and spreads very fast as well within the community. So it's that balance, I can imagine, you've got to have between having the authority, make sure you've got everything in place, but responding quickly as well. And I imagine that's a very fine, delicate balance you've got to get.
We hope you enjoyed today's episode. The next episode of the IDRiM podcast is due out later this week, and we hope to see you soon.